Hey, good morning, everyone. How y'all doing? Perfect. You guys are excited? It's your last day of farm for the semester? Till next semester? Hmm? I'll get started here in just a few minutes, but looks like I got a lot of questions on the sticky board, so I'll address those first, and then we'll go to our cases. Well, alright, let us begin. Looks like about 13 people in. I mean, there's probably a watch party going on too. So, let's start off by going over the questions up here on the sticky board. So I appreciate you guys using that. That's a good way to communicate questions, and that way everyone gets the benefit of hearing them, all at the same time, which is good. So anyway, first off, hello. I have a question about a drug you have not mentioned. Sorry. I've used aminophylline in practice before to reverse symptoms induced by regadenoson. I don't really know much or which class it falls into as far as mechanism of action, but I am curious why it is not used for commonly for cardiac symptom reversal. So it's a good question. So aminophylline is sort of an old school asthma drug that we don't use too frequently anymore. Theophylline is sort of the oral form, and so sometimes you'll see aminophylin's IV form. You'll see used as um, a for severe status asthmaticus or something like that. And so one of the benefits of it, it's actually an adenosine antagonist. And so we talked about adenosine too as being an agent that's able to, treats, PSVTs and things like that. And so that drug there for the use for the cardiac scan, I'm going to bring it up here actually. Show you all. So if you look here, you can actually go to the mechanism of action. This is just lexicon is what I use for my drug references typically. You can see a low affinity agonist for the adenosine receptor. So it increases coronary blood flow, mimics increase in cardiac blood flow caused by exercise. So that's why you end up using it for, a stress test, a chemically induced stress test to stress the heart out to see kind of what happens on for instance, like on the EKG, and then if they're having symptoms, you could reverse that because aminophylline can act as an adenosine receptor antagonist, so they kind of oppose each other in that way. So good question. That's basically where it comes to. So aminophylline, if you're using it for other purposes, it's not going to do anything for someone who's coming in with like a CHF exacerbation or anginal symptoms or something, because you don't have that adenosine that's actually there causing the symptoms in the first place, or something agonizes adenosine receptors. Someone said, just confirming the background information on the cardiac conduction phases of action potential EKG complex isn't going to be directly tested on, more so for purposes of understanding mechanism of action of antiarrhythmics. That is correct. The whole point being is that you need to kind of understand the underlying physiology, so that way you can understand how the drugs are affecting that. And so, some people, they think pharma is just a lot of memorization. There is to some degree. But I think if you intuitively know how these drugs are working in conjunction with how the normal physiology works, that makes it easier to remember that stuff. It's easier to understand how a class 1 antiarrhythmic acts differently than a class 3, and what type of clinical effects you could see with those if you understand the physiology, right? So for instance, with the class 1 A antiarrhythmic or 1C, if I were to look on an EKG, I'd expect to see QRS prolongation, which makes sense because it affects the sodium channels, causing that rapid influx of sodium is lengthening that, because it takes longer for the depolarization to occur. So sodium channels are blocked. Versus if I were looking at a class 3 antiarrhythmic, something like dofetilide or Tecousin, I wouldn't expect the QRS to prolong, because the drug has nothing to do with ventricular depolarization. It all affects the repolarization phase, the outward flow of potassium. So if I'm blocking that, then I expect the QTC to prolong rather than the QRS. Okay, so understanding the underlying physiology is the whole point of that, why I cover that, to make sure we're all on the same page. So no, I'm not going to have a specific question on the test saying what happens during phase 3 of the cardiac conduction cycle. I don't really, that doesn't really apply to our purposes here. I want to focus on the medications. Someone said, I'm wondering if all drug names for the different types of androgens are fair game. There are a lot given and 3 methods of admin. Are there any main ones we should focus on? You should at least be able to recognize that it's an androgen. If I point one out on the test, also knowing about the different routes of administration is important, because that affects certain side effects you can see with those drugs there. So again, be able to identify those. Obviously, testosterone is the most common one you're going to see being used there, but other than that, you should just be able to identify it, I would say. Okay, so good morning. Will most of the questions for this upcoming test be similar to the last, where you present a vignette? Thank you. There will be a mix. I think it's important to have different levels of questions on an exam. Not all of them are going to be, a page-long vignettes to about the clinical applications. Some of it's just going to be, kind of an information check, just to make sure you understand, the basics of the drugs, like what's the most common side effect of this, what is, a contraindication of this drug, etc. So there'll be a mix. There'll still be some vignettes, but again, it'll be some level 1 questions, level 2 questions, and then those more difficult level 3 and 4 questions. Okay, can you briefly go over which antiarrhythmic classes control rate and which ones control rhythm? Thank you. So again, this goes back to understanding the underlying physiology and being able to understand how the drugs are working, what they're going to do. So if a drug is affecting primarily nodal conduction, SA and AV node, and how fast those signals coming from the atria are being sent down into the ventricles, right? So think like AFib. Anything that's slowing that down is considered to be rate control, because they affect the rate that those signals are being sent down. They can affect the heart rate. So which classes of drugs do we look at that mostly affect heart rate? Well, it was your class 2 and 4, your beta blockers and your non-dihydropyridines, right? Versus if the drug is directly fixing the arrhythmia, if the goal is to put you back into sinus rhythm, something like a class 1 or a class 3, because they're directly affecting how the action potentials are developing or how they're resetting themselves, then that's going to be more of the form of rhythm control, right? So as an example, I'm not sure if I mentioned this one last week at all, but for instance, if we have, say, a 10-month-old comes into the ER and they're in PSVT and they're tacking away at like close to 200 beats a minute or something like that, there's different means in order to try to treat that patient, right? So you can try to go with a means of rhythm control, where I try to put the patient back in a normal sinus rhythm. So in that case, something like adenosine can be used for that particular case. That doesn't work, you can use things like amiodarone. And then on the other hand, if you want to try to slow down that rate to make sure the ventricles have time to pump efficiently, to not tire out the ventricles, because when they start to tire out, that's when your cardiac output tanks. That's when they decompensate, and that's when you can really run into problems. So in those cases there, if I just want to slow things down, I could use something like a cardizem drip. I could use diltiazem to try to slow that down and keep the patient at a reasonable heart rate. So hopefully that makes some sense in terms of how to delineate between those. Someone said, good morning. Good morning to you as well. Just wonder if you can go through the basics that you want us to know for the steps of iodine trapping, please, and thank you. This is more so, again, getting the underlying physiology under with your understanding. So, you know, am I going to ask you specifics about all the steps of producing T3 and T4? No, but I put that in there so that way you understand the importance of, like, why is it that you know, iodine having a deficiency of that ends up leading to hypothyroidism, right? And how we can end up treating that, or also how by providing too much iodine, we can stop that process as well. Because it sounds kind of counterintuitive. It's like you need iodine in order to produce thyroid hormone, but if you have too much of it, it can actually inhibit that. So again, more so just to get you on the baseline in terms of what you know, should understand about the physiology. I'm going to focus more on the drugs though. All right, someone said, do you mind going over mechanisms of action for alpha antagonists versus alpha agonists versus central sympatholytics? Are clonidine and guanfacine both alpha agonists and central sympatholytics? I'm having a hard time understanding when you would use one of these three over the other. Okay, so there are two main varieties of alpha receptors you're going to run into, alpha 1 and alpha 2. Alpha 2 are primarily found more so like in the CNS. Okay, alpha 1 is one you think about as affecting mostly your vascular smooth muscle, right? So if I have something that agonizes the alpha 1 receptors, I'm going to expect to see vasoconstriction. And that makes sense when you think about drugs like pseudoephedrine, right? Pseudoephedrine, we talked about in the ENT section, causes vasoconstriction in the nose, so that way you don't have a runny nose anymore, right? It causes increases in blood pressure because you see alpha 1 agonism causing constriction there, okay? So an alpha blocker like doxazosine, prazosin, or something like that would directly antagonize that and cause vascular smooth muscle relaxation, and that's how you end up seeing the lowering of blood pressure. But again, that's also why you end up seeing reflex tachycardia, because the SVR is down. Now your cardiac output wants to play catch up and all of that. So that's alpha 1 receptors. Alpha 2, on the other hand, are going to be more so seen in the CNS, right? And that's where we get the term central sympatholytic. It's decreasing the activity of the sympathetic nervous system by activating alpha 2 receptors. Essentially, what that means is that alpha 2 receptors are responsible for shutting down production or release of norepinephrine, right? So something like clonidine or guanfacine is going to work up in the brain to decrease release of norepinephrine, and thus downstream from that, if you go back to the vascular smooth muscle, there's no norepinephrine affecting those alpha 1 receptors. So it doesn't directly antagonize those receptors like clonidine doesn't, but it shuts down the thing that would normally activate them, that would normally agonize them. So in that way, you get similar effects. But the thing with the central sympatholytic is it just doesn't affect the alpha 1 receptors, because norepi affects alphas, betas, and all of that. So with something like prazosin, it's a very narrow activity. It's only affecting alpha 1 receptors. On the other hand, though, something like clonidine blocking the release of norepi affects both beta and alpha receptors. So that's why you end up seeing something like clonidine causing bradycardia and hypotension versus something like prazosin causing hypotension and tachycardia, right? Again, if you understand the underlying or the physiology of what those adrenergic receptors do, and then how the drugs interact with that again will help to make it more intuitive sense. So when would you use one versus the other? Stay away from your alpha 1 blockers in general, right? There are some cases where you can use it if you have patients who have like BPH, for instance, which we'll talk about next semester. That can be useful because it helps to relax the prostate, for instance, for better urine flow. On the other hand, you can use an alpha blocker if they're like on 2 or 3 other meds already and you need something additional to try to get blood pressure under control. you can try that. They're probably already on a beta blocker by that point anyway. But again, side effect profile is not great with those drugs because a lot of the orthostatic hypotension tends to be pretty severe with that. There's that. On the other hand, though, something like clonidine can be used by itself as monotherapy. It's not done frequently, but sometimes you will see that. We use clonidine and for other things too. We can see it used for ADHD. We see it used for spinal anesthesia, all kinds of things. So hopefully that gave you a decent overview of all of it. Okay, could you give a brief example of how non-DHPs are CYP3A4 inhibitors and substrates? I feel like I understand it, but I want to make sure. Yes. Okay, so if I have someone who's on verapamil, okay, so they're on a non-DHP, and then they are started on something like, say for instance, grapefruit juice. They start drinking grapefruit juice. That inhibits CYP3A4. Verapamil levels are going to go up. Why is that? Because you have something like grapefruit juice is inhibiting CYP3A4. Verapamil is the substrate of CYP3A4, and thus it's inhibited, so those levels will go up, right? So that's where you're more likely to see hypotension, bradycardia, constipation, peripheral edema, all that stuff that goes along with the non-DHPs you can see there, right? So that's one way. If I have someone who's taking simvastatin, which is a CYP3A4 substrate, and then, sneeze it. Sorry about that. If I have someone who's taking simvastatin, for instance, and which is a CYP3A4 substrate, and then I add on verapamil, that is going to cause levels of simvastatin to go up. Okay? Because verapamil is a CYP3A4 inhibitor. So if I have someone who's on verapamil and simvastatin, let's say they're both on a steady dose of both, they've taken into account the drug interaction, and so the levels are fine. If you put them on or have them start taking grapefruit juice, then levels of both verapamil and simvastatin are going to go up. Because again, you have additional inhibition of CYP3A4. Okay? So that makes sense. So again, drugs can have multiple actions here. They can be both a substrate and an inhibitor. Sometimes they're a substrate and an inducer. We'll talk about a case like that when we get into the neurology section next semester about a drug that undergoes auto-induction of its own metabolism. And so there's a certain dosing strategy you have to use to get around that. So hope that makes sense. If you have additional follow-up questions in the chat, please post them up. That's totally fine. Okay, why would you use a thiazide as first-line treatment for hypertension when loop diuretics are more potent? Thanks. A lot of reasons, right? Remember, loop diuretics are bad antihypertensives. You don't use them as antihypertensives in general, right? Loop diuretics are meant to get rid of fluid off the body, right? If the hypertension is due solely to that buildup of fluid in an acute sense, then yeah, those can help. And that's going to be more like on an in-hospital sort of sense there. But chronically, what we're finding is that you can give someone a loop diuretic, and in the short term, that will help to get their blood pressure down because there's just less fluid in the vessels. However, the body doesn't like that, right? It resists change due to its homeostatic functions, right? So what we're going to see is that you'll have upregulations and counter-regulatory systems to counteract the effects of that furosemide, for instance. So the RAS system is going to be upregulated. The sympathetic nervous system is going to be upregulated. Your ADH is upregulated. All these things will go to counteract the effects of furosemide over the long term, such that the blood pressure is going to be either back to normal, maybe higher than it was in the first place. So again, that's over a chronic sort of period there. But thiazides, on the other hand, while they are wimpier in terms of the amount of diuresis you're going to see there, they have those other benefits that we talked about, right? So they have the benefits of helping out with the water logging. You can see the vessels. So by actually, for some of these patients that are in a very what we call salt retentive state, they hold on to salt in the vessels, and that causes them to thicken up, right? Because wherever salt goes, water wants to follow it. And so if you decrease the diameter of the blood vessels, then the pressure is going to go up because there's less room for all that fluid. But chronically, you're going to find that thiazides help to decrease that water logging. The vessels will sort of have a bigger diameter, pressure goes down. So that's why you use thiazides for first-line hypertension versus loops you really don't use for hypertension specifically. Okay, someone said, when I was completing the quiz, I found it difficult to try and figure out which side effect you were looking for as the answer because so many overlapped. When we're studying for this test, should we use the quiz to gauge what side effects are most important for that drug? Yeah, so like, for instance, if you read my test questions, you're going to notice that I say, what is the thing that is most likely to cause this? Or which of the thing is the best therapy for this? we word that very specifically because, yeah, there could be multiple drugs that have similar side effects, but there may be one that really is much more likely to cause that a side effect than others. And so that's what we're really looking for. And so that's why, you can come up and argue and say, well, technically this drug could do this too. And I say, I didn't ask the question of which one could do this. I said, which one is most likely to do this, right? So kind of the tricky way teachers get at students want to argue questions. Kidding. But it's to illustrate the point that some of these drugs are more prone to causing these things than others. So, for instance, something like, let's say, a loop diuretic versus an alpha 1 blocker. Can a loop diuretic cause orthostatic hypotension? Technically, yeah, it could probably do that if you have enough fluid, if you have enough diuresis occurring there where blood volume's low, they get dehydrated, and they stand up. Yeah, could they get dizzy and fall? For sure, right? But if you have something that is directly antagonizing alpha 1 receptors and causing those vessels to blow up and dilate, that's much more likely to cause that. And that's, again, a much more likely side effect to occur with that particular drug. I'd be more likely to tell a patient about that side effect with that than I would for something like a loop diuretic, for instance. So hopefully that makes a sense. If not, let me know. Very good. So hopefully that was a nice review for some of you. Odalis is saying, can you go over meiosis and the correlation with clonidine? It was on the quiz, but I don't remember why it specifically spoke about that or regarding its MOA. So, right, that goes back to the central sympatholytic effects there. Basically, what you're going to see is that by decreasing the activity of the sympathetic nervous system, that affects everywhere, right? Not just the heart, not just the blood vessels, but affects everything. So, where might you see that occur? That sneeze is finally coming. Not gonna happen. I apologize. I know it's like you guys are waiting in anticipation for my sneeze to happen, but it's just not. It gets shy, I guess. Um. So anyway, that central sympatholytic affects everything. So that can affect the eyes as well, right? So that's something that I usually mention, and if it's not on the slide specifically, I typically talk about it. But that's why, for instance, with like clonidine, you can see that for a patient who accidentally has like an exposure, like say like a little kid gets into a clonidine patch or something. You can see meiosis because, and that makes sense because if you're decreasing the effects of norepinephrine on the eyes, well, what does that do to your pupils? Well, it causes them to constrict. Because if you think about a typical fight or flight response where you have norepinephrine affecting the eyes, if you're running away from a threat, you want as much light to come into your eyes as possible because you're trying to see all the threats that are out there so you can run away from them or fight them. On the other hand, though, if I take away that effect, take away that norepinephrine, that will cause meiosis cause constriction of the pupil because, again, you're missing that norepi effect. Okay, so it constricts down. So, and I can use that clinically too. It's very helpful because if I have a patient who has an unknown overdose, I can look at their signs and symptoms to see what particular things they're exhibiting, and that will give me a clue to what they might have been exposed to. So, for instance, if I see, and I had a case just like this where a 10-month-old comes in, is lethargic, not eating right, just like really difficult to wake up. Blood pressure, heart rate are pretty marginal. And so they're like, well, what does this kid get into? Does he have meningitis? Does he have, and all the normal medical stuff they'd work the kid up for was negative. And so they consulted me because they're curious to see could there be any sort of drug exposure. And I was interviewing the parents and saying, well, okay, what kind of medications are in the home? The kid's not on anything. And the dad said he was on a clonidine patch. And so when I examined the kid, CNS depressed, had meiosis, I was like, okay, this looks a lot like a clonidine exposure, and we're able to treat it like that. Even though the dad was like, well, he's 10 months old, he's not really moving around that much, he couldn't have got one of my clonidine patches. And I said, well, does the kid have a big brother or a big sister? And he goes, oh yeah, he has a 2-year-old at home. And so I said, okay, well, do you just throw your patches into the trash normally when you're done? And he's like, well, yeah. And I go, okay, well, sometimes what happens is big brother, big sister, they want to take care of their little sibling, and so they will grab a patch out of the trash or something and feed it to the kid. He's like, no, that's absolutely no way that's possible. That would never happen. My kid would never do that. I said, okay, well, it looked enough like a clonidine overdose, so we treated it as such, and there's a certain antidote you can give, and the kid started waking up, and it seemed very likely that was the case there. So anyway, we, managing the kid in the ICU. 2 days later, guess what happens? Poops out the clonidine patch. So Again, it's one of those things where even unlikely, it's like playing house or something. Not playing house, but like the show house. We have to be kind of a detective and go off the signs and symptoms you're seeing and see what it is consistent with. In that case, there things were very consistent with clonidine overdose, and so we were able to come up with our diagnosis, and it was proved out to be true. So anyway, all right, moving on. Let's talk about a couple of cases here, just to give you some ideas of how we think about these things clinically and some of the things that you want to think about when you were perhaps answering some of these questions on a test, or if you're going to be seeing these type of patients coming up. Hopefully this is going to be, this will comport with your medicine classes. If there's anything that seems contradictory, you just let me know. We can talk about it. So a couple cardiology cases here. Let's talk about someone with heart failure. So let's say we have, and hopefully you guys can see the slides posted up. Sometimes I've been more short of breath lately. I can't seem to walk as far as I used to, and either my feet are growing or my shoes are shrinking, right? And so this is a 68-year-old African American lady coming in to talk to her family medicine physician, or I guess a family medicine PA. And she's having this increase, in shortness of breath, increased swelling of her lower extremities. And so they've noticed over the course of about 4 days or so, right? She also noticed it particularly when she's lying in bed at night, right? So I should start to kind of clue in on a couple of things going on here. And she's using 3 pills in order to help her get to sleep, right? So you'll oftentimes ask those patients, like, how many pillows do you need to prop yourself up with? And then she also reports exertional dyspnea, which is usual, but seems to be worse over the past couple of days, okay? In terms of past medical history, he's been hypertensive for a long time, has a history of MI back in 2005 where they did a PCA with a couple of stents, or PCI with a couple of stents, has heart failure, type 2 diabetes, AFib, COPD, and CKD stage 4. Now, we haven't talked about all these disease states yet, and so if anything comes up where it refers to a drug that we haven't talked about, I'll kind of mention those, but obviously those drugs will not be on the test. But this is how people present. They have a gazillion disease states, they have, a dozen or more medications are on, and so you got to kind of make sense of it. This is why family practice can be so challenging, just because you're having to deal with everything. You don't get to be specialized and just do one, just do the cardiology stuff or just do the diabetes stuff. But anyway, talking about her social history, occasional drinker, states she's been trying to follow a low cholesterol, low sodium diet, used to be a smoker, but quit 10 years ago. Okay, so let's look at our medication list here. And so again, you should be able to start to kind of go through a patient's medication list and sort of piece together, what are they on, what kind of drug is that, and why are they taking this particular drug. So first off, we have valsartan, right? So valsartan, you should be thinking, okay, that's going to be an ARB. Okay, does this type of patient make sense to be on an ARB? Well, absolutely, right? Because they have heart failure. That makes sense. That's one of those mandatory meds they need to be on. They're taking Lasix, 40 milligrams POBID. Does that make sense? Yeah, they have heart failure, so they need to get rid of that fluid. Obviously, it doesn't seem like it's working because she has coming up with the swelling that she's been reporting over the past few days, right? She's on warfarin. Well, why would she be on a blood thinner? Why is she on an anticoagulant? Does that make sense? Well, look at her past medical history. She has a fib, which does make sense. We talked about that as being, a common indication for warfarin. We'll say this is before she had access to some of those NOACs we talked about towards the earlier part of the class. Carvedilol, beta blocker. Makes sense. She's got heart failure. Okay. Pioglitazone, glimepiride. These are actually going to be drugs we'll talk about when we get into talking about diabetes next semester, but these are used to control her sugars. She's on KCL. Why is she on potassium chloride? Why would that be? Well, she's on Lasix too, right? And again, we see she's on a medication that can actually raise up your potassium like valsartan, but again, maybe her potassium was found to be low before, so we can check that out and see what her potassium is today. She's on atorvastatin. Does that make sense? She has a previous MI, so she absolutely needs to be on one of these in order to help prolong her life if possible. Aspirin for secondary prevention of cardiac events makes sense. And then she's on albuterol, tiotropium, and then a combination of fluticasone and salmeterol for control over COPD, and she has asthma too, right? Just COPD, so she's on control for that. Okay. And in terms of allergies, just lisinopril, which is cough. Now notice here, would you ever say that that's a true allergy? I wouldn't. I'd say that's a side effect. Does that get listed quite frequently as an allergy? All the time. So again, that's why it's very important. If you saw someone had a allergy to lisinopril, I would probably think right off the bat angioedema. But if you then ask to say, well, what was the reaction that you had? And they said, oh, I had a bad cough, so that's why they switched me over to valsartan. That makes more sense, right? So anyway, sorry, this is a little bit tiny here, but looking at her review of systems, we can see here she's had a 7 kilogram weight gain over the past week. So that's important to know. So she's definitely packing on. And again, is that just fat? Well, no, it's it's over the course of a week, and it's like 14 some odd, 15 some odd pounds. That's more likely to be due to fluid, right? Which kind of makes sense based off of her production or her presentation here. Um, Talked about having that shortness of breath, a 3 pillar orthopnea, talking about non-productive chronic dry cough, which is usual without recent worsening. Let's see here, nothing else notable with that. Now, vital signs I will make note of, make sure that this is consistent with what we were talking about earlier. So BP 134/76. So is her blood pressure under control? Mostly, right? If your repeat is 138/70, it's not, mostly under control. Probably not as tight as we would like it, but mostly okay. Has a heart rate of 65. Notice irregularly irregular. So that is, due to the AFib, right? Remember the Carvedilol before we saw is good for the AFib, but also helps out with the AFib as a means of rate control, right? So, is she sufficiently beta blocked? Well, heart rate is 65. That's pretty good, right? Anything less than 60 would be considered to be bradycardia, right? Respiratory rate's a little high, so again, that kind of speaks to that dyspnea she's developing there. Temperature's fine. O2 stat's only 90% on room air, so that should be concerning. And again, why are you thinking she's got a low O2 stat? Well, probably because all that fluid's building up on her lungs because of the CHF exacerbation, preventing exchange of oxygen, right? And then you can see the weight there, about a 7 kilogram bump. So anyway, so color's pale, diaphoretic, makes sense there. Looking at other stuff here, we see things like JVD, all the good stuff with the physical exam that I don't really get into because it's not really my specialty, but certainly you guys will know most about all of that. And again, this looks like a pretty classic CHF exacerbation. So let's look at the electrolytes to see if anything is funky here that makes sense based off of kind of the medications that she's on. So right away, notice that the sodium is 131. Usually a normal is like 135 to 145. So why would she have low sodium? Well, she's on a loop diuretic, right? So that makes sense. You would lose sodium. That's the mechanism of the drug. That's how it works, right? Now again, are you gonna find everyone who's on a loop to have hyponatremia? Not necessarily, but she's been trying to adhere to a low sodium diet. Maybe she's been successful. Who knows, right? Potassium 3.5, which is kind of borderline on the low side, but it still is considered normal. Looking at other stuff here, we can see serum creatinine is elevated. Now, again, anytime you see an abnormal lab, you want to see what their baseline is. And so in this case here, she's normally sitting about 2.1, and she's at 2.3 today, which sort of makes sense. And again, this is pretty progressive kidney dysfunction. If you look at her creatinine clearance, it's about 30.2 mLs a minute. So not great, right? And so that'll be important when we talk about some of our medications here in just a little bit. Other than that, it looks like her sugars are under control. Her INR is in range for AFib. Remember, 2 to 3 is normally what we're going to be looking for there. And then you can see her BNP is elevated, so certainly speaks to the CHF exacerbation. On the echo, you end up seeing reduced, ejection fraction. We certainly see LVH happening there. And then on the EKG was atrial fibrillation with left ventricular hypertrophy. All that makes pretty good sense. And then when you're looking at the chest x-ray here, you notice some cardiomegaly. You got a big boot-shaped heart, as they talk about, with some interstitial edema, some early alveolar edema, right? So that makes sense given the fact that we talked about that fluid being on the lung. Our O2 sats were low, on room air. That all seems pretty consistent. So ultimately, what is this patient's main problem? So why is this patient presenting today? Well, because she's having this swelling, she's having this increased dyspnea. She appears to be in a CHF decompensation, right? So she's not looking too good right now. Vital seems stable, but again, it's not. So sometimes when you're going through these cases, you want to think about, well, is this patient stable or unstable? Vital signs were looking okay. She's just really symptomatic. Do you need to rush this patient to the ER? Maybe not in this case here. There may be some things we can still do while we're in the primary care office, right? So obviously the main problem there we think is probably CHF exacerbation here. So how should the patient be managed at this time? Which meds should we continue, add, or discontinue? Okay. So what do we think in terms of this? So if you have any ideas, you can go ahead and post them up on the chat there. But so looking at this, obviously fluid is going to be one of the big problems the patient's developing here, right? So this patient's having fluid buildup. So how can we get rid of that fluid? How can we do that? Well, she's already on Lasix, 40 milligrams BID, which is not the biggest dose you'll ever see, but it's certainly not nothing. So could we do other things to try to get more fluid off of that patient there? So yeah, so could we go up on the dose of Lasix? For sure, right? But remember that that's also going to worsen the potassium levels and things like that. So it's something you want to keep in mind, right? But what else could we do? Could we add on something else that could help out with that fluid elimination, right? Oh, someone's got a very good idea. Thiazide diuretic. So that is something that you will see with these patients. If they're on loops for a long period of time, they get what they call loop resistance, where they actually find that their distal convoluted tubule is trying to make up for the loop, losing all that sodium and potassium and whatnot. So it'll try to pick up the pace a little bit there. So in order to overcome loop resistance, you could utilize something like a thiazide diuretic, right? Now, would this patient be contraindicated from getting a something like a potassium-sparing diuretic? Not necessarily either, right? Obviously, those are not going to be as potent of a diuretic as you would see with something like a thiazide, though. So I think that thiazide is a good place to start with. However, remember when we talked about thiazides that even though loops can work no matter what the patient's creatinine clearance is, they always continue to retain some efficacy. That's not the case with thiazides. Remember that you end up losing thiazide, their abilities to increase urine flow tends to go down once you get to creatinine clearances around 30 or so. So this might be a good case where I wouldn't want to use something like HCTZ, for instance, but something like that still retains activity even at low creatinine clearances might be a better option. So something like metolazone might actually be a really good option there, or Zeroxalin's a brand name. I apologize. I feel like it's like imminent and then it just goes away. It's very annoying. I'd rather just get it over and done with. You're right. So something like metolazone or Zeroxalin would actually be a really good add-on medication here to help overcome some of that loop resistance and help to get rid of some of that fluid there, right? And again, I said this isn't a patient you necessarily need to send to like the ER right away. Depending on how she looks, you may be more or less likely to do that. But looking at her vital signs, she's still considered somewhat it's considered to be somewhat stable, I would say. Now, keep in mind she also has COPD, so that could be affecting her oxygen as well. So, kind of two concomitant things sort of going on there to kind of consider, right? So that would probably be the best thing. Now, in terms of like management, are there other things that we could do necessarily in order to help her out? I don't know if you could always consider, especially if her blood pressure was not really that well controlled, you may consider modifying doses, some things, but also think about if she is not perfusing very well because she's not able to pump very well, you may want to get rid of things that could be worsening that. And so this could be a case where even though patients like this probably need to be on beta blockers chronically, a beta blocker could be exacerbating her case right now, right? Because it could be decreasing heart rate to the point in contractility to where she can't really keep up necessarily with the extra fluid that she's pumping against, right? Because again, what is this patient's like? What's the pathophysiology here? She has extra fluid she's holding on to, probably because she can't get rid of it because of her kidney disease. That's increasing afterload that the heart's trying to pump against, so that is causing the failure, right? Because she's been hypertensive for a long period of time now, and that's had this damage to the heart and to the kidneys over time, and so that's the issue. So probably my first step would be to get the fluid off, right? So that would include adding on the thiazide, adding on metolazone, seeing how she does with that. And then, for someone like this too, if they're coming inpatient, they probably put like on a Lasix strip, for instance, to help get rid of that fluid. The other thing to consider too would be to get rid of that beta blocker, but I would want to maybe be a little more cautious with that because again, she is in AFib, so of course we would see some issues with that potentially if you abruptly DC'd your beta blocker. So that's not something you want to stop right away necessarily. And so that'd probably be it for the most part. And again, you probably want to follow up with her very closely. If not, if you're not sending her off to, an inpatient stay to get sort of fixed up there. Again, the O2 sat's a little bit concerning for sure. And so that may lead you to decide to, send that patient into the ER, for instance, for an admission potentially. So Other than that, sugars look okay. Do you need to stop the atorvastatin or the aspirin? Probably not. The warfarin looked okay with it where it's at. So really, just the acute issue here is the fluid you need to get rid of, and so that's where something like a thiazide could be very beneficial, right? So again, ultimately not doing a whole lot for that patient necessarily in terms of changes, but again, you can see there's a lot of thought that goes into it with all the other stuff going on with the patient at the same time. And again, you want to think about if you're initiating something or DCing something, discontinuing something, you want to consider how that's going to affect their other disease states. So you could say, yeah, she's in a CHF exacerbation. Let's go ahead and stop the beta blocker. How is that going to affect her AFib, right? How is that going to affect these other things you could see some interactions with? So always something to consider. Okay, let's say we have a hypertension case here. So, guys coming in, 64-year-old black man's coming in saying, hey, I'm here to see my new doctor for a checkup, my new PA for a checkup. Just getting over a cold. Overall, I'm feeling fine, except for an occasional headache and some dizziness in the morning. Other doctor prescribed a low-salt diet for me, but I don't like it. Typical patients, right? They don't like the stuff you tell them to do, even though it'll save their life. So he's presenting to the family medicine practice here for some follow-up on his medical problems. Generally no complaints except for some headaches and some dizziness when he takes his morning medications. Okay, so that should clue you into something right there. States he's dissatisfied with his low-sodium diet that his prior provider told him to do. You can see here is hypertension of 14 years, type 2 diabetes, COPD, BPH, so benign prostatic hypertrophy, CKD, and gout. Again, you're going to see these patients that have a multitude of different disease states, some of which may be intertwined in terms of their how they develop that. So, for instance, having hypertension for a long time can cause kidney disease, etc. Right? Anyway, so looking at the social history here, used to be a smoker, pretty decently heavy smoker there. Talks about moderate alcohol intake, admits he's not adherent to his diet. He eats whatever he wants and does not exercise unless he's walking around Walmart, all of that, right? Or works at Walmart, so I guess he probably does get some exercise walking around there. Okay, so looking at his medication list, so let's see what he's on. So he's on triamterene hydrochlorothiazide, so he's on a thiazide diuretic with a potassium-sparing diuretic, most likely for hypertension. Makes sense. Insulin glargine and Lispro. So those are two types of insulins we'll talk about next semester that you're going to see being used to help control sugars. Okay. He's on doxazosin, which is going to be a alpha 1 blocker that we mentioned. He's on carvedilol, which is a beta blocker. Albuterol, tiotropium, fluticasone, salmeterol, again, going to be seen used for the COPD. He's on Mucinex D. If you recall back from the ENT section, we talked about that being cough suppressant. If you ever see Mucinex itself is guaifenesin, if you ever see a D on something on an over-the-counter, that usually means it contains dextromethorphan. So cough suppressant along with a mucolytic there. And then naproxen, which is we know is to be an NSAID over the counter, and then allopurinol, which is something we'll see used for is gout. Okay. So patient states overall is feeling well. No major weight changes over the past few years. Talks about some occasional headaches that are relieved by that naproxen there. Denies any kind of blurry vision, chest pain, anything that's kind of worrisome like that. State shortness of breath is pretty usual for him, but his albuterol does help out. And then he's had 2 exacerbations of his COPD in the past 12 months or so. Denies experiencing any epistaxis, hemoptysis, etc. I'm trying to see if there's anything else really notable in here. Talks about gout pain being relieved with naproxen. Denies urinary frequency, but had problems urinating until he got put on that doxazosin. That goes back to what we were talking about with having an alpha blocker being useful for treating the BPH, right? Because it helps to relax the prostate so that way you can get better flow through the urethra. So looking at the physical exam, let's focus on the vital signs because, again, usually when you walk in a room, if they're on a monitor, that's the first thing you're going to see, right? BP 162 over 90. So is he under control? Obviously not, right? This is pretty clear cut stage 2 hypertension here. Looking at his heart rate is about 76. Okay. Remember he's on a beta blocker. Respiratory is 16. That looks okay. Let's see if he is. No O2 was measured there. Other than that, nothing crazy on the physical exam. Obviously, prostate's enlarged. It looks fine there. Looking at his labs, I don't see anything too crazy besides the fact that serum creatinine is elevated. Okay, so it's notable there. Glucose relatively okay. Other than that, I don't want to get into his pulmonary stuff, but those creatinine clearance about 39, so pretty diminished, but not the worst we've ever seen, right? I can also look at his cholesterol here to see if those look okay. Yeah, looks pretty okay for the most part. So what's the patient's main problem? Again, he's not really complaining anything other than he doesn't want to be on a low salt diet. But we do notice he's got his hypertension is really not under control, right? Currently, what is he on for his blood pressure? Well, he's on triamcinolone hydrochlorothiazide, he's on a beta blocker, and that doxazosin is contributing to the blood pressure lowering effects. But again, they're not necessarily using it just for that, using it for the BPH mainly. So how should we manage this patient at this point? What meds should we add, continue, or discontinue? So let's look at it. So based off of this, we understand. And so Savannah's saying, could we add an ACE inhibitor since he's a diabetic with hypertension? That's a very good question. I think you beat me to it. Yeah, so the first thing when I'm looking at this patient's medication list is the fact it's a type 2 diabetic patient with chronic kidney disease. They probably should have been on an ACE inhibitor years ago, right? So that's a definite add-on. So you could do something like lisinopril. You could do something like ARB. Any of those are totally fine, right? Consider, though, what was his potassium to begin with? If you go back and look at his labs, it's already 4.7. So if I add that on, is that going to potentially put him into a state where he's hyperkalemic? Potentially, right? So that's something you would definitely want to monitor for and have him come back in a couple of weeks, a month or so to see where his labs are looking at. Now, what could I do instead if I didn't want to necessarily monkey around with potassium too much? Well, I could maybe switch them out. Maybe instead of using triamcinolone hydrochlorothiazide, I switch out the triamcinolone for an ACE inhibitor. That way, maybe I do lisinopril hydrochlorothiazide together as a combo. So now he's still taking the same number of meds. It's just now we may be on a more optimized therapy here. Now, what Alice is saying, should we also consider he's African American? That is certainly a consideration too. But remember, certain things will kind of override that. So if you have certain things like compelling indications that would lead you to think about using one med over another, the diabetes is the big thing here, right? But also remember for black patients, they tend to respond well to hydrochlorothiazide, things like calcium channel blockers. So I would keep that in the back of my mind. I would definitely get the ACE inhibitor on board first. Try to see how that's going to handle the patient, see how that's going to do. I want to see what his labs are going to look like after that, and then see if that gets him under control, right? Now he's sitting at 162 over 90. So it's just the addition of the ACE inhibitor going to be able to be the only thing that's going to fix it? Not necessarily, right? So we'd have to figure that out to see, okay, well, how much of a drop are we going to get there, and then maybe add on something else from there. Also consider, too, what else was the patient complaining of? And again, they'll say stuff that they don't realize is, they're not coming up complaining because of this thing, but they kind of say it and it makes you think, okay, there's something else going on here too. Remember, he said that he gets dizzy in the morning when he takes his medications, right? Well, what does he take in the morning? Well, you notice he takes that doxazosin for his BPH, right? So it's maybe a consideration where getting him off the doxazosin could be a good option as well, and maybe trading that out for something as well for BPH. We'll talk about other meds we can use for that next semester, but sometimes by switching them to a much more selective alpha blocker for the prostate can be helpful. So if you ever heard of like Flomax, that's something we use sometimes. Another option could be something like a drug that blocks androgen effects. If you use like something I know we talked about it, like dutasteride or finasteride, that prevents conversion of testosterone to DHT, that also helps kind of shrink down the prostate. So that could be a consideration for this patient as well, because it's probably the doxazosin is not doing him a whole lot of good, and he's also having that dizziness to go along with that. So that's something I would certainly consider there. Okay. So, right. So I would definitely get the ACE inhibitor on board, see how that's going to work for the patient there. If that's still not getting things under control, you may want to consider something like a calcium channel blocker, and probably thinking like a DHP, because he's already on Provedolol, so you don't necessarily need to add on a non-DHP because that's going to drop his heart rate too much. I wouldn't want to do that. So overall, I think that would probably be a good plan for someone like this. Again, could you bump them up to a higher dose of hydrochlorothiazide? For sure. So maybe you'd want to do something like lisinopril 10, hydrochlorothiazide 50, and maybe see how the blood pressure does with that. It'd probably be the first change I'd make, and then DC the doxazosin or to get something else like Flomax or Proscar, something like that on board. So hopefully that makes sense. Remember too, the more heavily diuresis patient, the more likely you are to have gouty attacks, because that causes all that uric acid to sort of contract in terms of volume, so it gets more concentrated. So you do want to watch out for uric acid levels there and make sure that he's aware of any increase in gouty-like symptoms. Okay, so let me know if you have any questions about that. A couple more cases here. I think I just have just one case. Okay, so our third and final case here. If there's any questions up on the board. No, nothing there. Okay, so let's talk about an anginal case here. So we have a patient saying these drugs just aren't working for my chest pain anymore. You have Jack Palmer's a 72-year-old gentleman with coronary artery disease. He's an avid golfer, prefers to walk the course, but it's just being more difficult for him nowadays. Having all these chest pains is sort of slowing him down. He's had 2 coronary artery bypass operations in the past. They did an angiogram about a month ago, revealed significant disease in the right coronary artery, proximal to the graft, and then he was considered high risk for angioplasty. So currently his dose of isosorbide mononitrate was increased at that time from 60 to 120. So we see he's on a long-acting nitrate. So that's one thing you want to know. Still had no effect on his angina. He's still using 30 nitroglycerin tablets a week, right? That's pretty frequently, right? So, it's probably like 5 to 6 a day in some cases. So pretty frequent there. And these maybe 4 to 5, and these do relieve his chest pain. He reports that most often chest discomfort comes with activity, such as walking up slight inclines. Discomfort is located in his center of the chest, 3 to 4 out of 10 on average. Okay. Reports that it will slowly fade as he slows his activity. Also complains of lightheadedness and pulse around 50 beats per minute, into something, and systolic blood pressure near 100 millimeters of mercury. Okay, so let's look at this guy's past medical history. We talked about the MI with the cabbage surgeries, got dyslipidemia, chronic low back pain, and depression. Looking at his social history, nothing super important there. Previous smoker. And let's look at his medication list. Okay, so he's on carvedilol, he's on lisinopril, he's on aspirin, on the isosorbide mononitrate, which is a long-acting nitrate there. On diltiazem, on St. John's wort, celecoxib, which is a type of NSAID, probably used for low back pain. It's on simvastatin and the nitroglycerin. So just looking at this, is there any kind of like big red flags based off of the presentation and what we're seeing in the medication list here? See if you can kind of consider that. See if you can kind of see if there's anything that should be like kind of piquing your interest, right, when you're looking at the medication list. Looking at his ROS, you can see he's had no recent illness, no shortness of breath necessarily other than with the activity, no myalgias, etc. Looking at his physical exam, also be something to look at. His blood pressure is 105/68. His pulse is 50. Is that normal? Probably not. Actually looks pretty low for a patient like that. The respiratory rate's a little elevated. Temperature's fine. All that. Looking at in terms of physical exam, I think nothing else really notable there necessarily. Looking at the labs, you can see here, looking for anything that looks super abnormal. Glucose is okay, serum creatinine's good, hemoglobin looks fine. Looking at his lipid profile, now again, obviously this is a very high risk patient, so he's on, I mentioned he's on, what is it, simvastatin? Yeah, 40. So that's another thing we'll look at there to note. Note his cholesterol it looks still elevated. Triglycerides are high. LDL is still a little high for this type of patient here. HDLs are low. And then on the EKG, we see sinus rhythm. First degree AV block, notable. 50 beats per minute. Old anterior wall MI. No ST T wave changes noted. QT 406. Okay. So, what is this patient's main problem, and how should we manage it at this point? What med should we discontinue, add, or change? What should we do here? Okay. So we'll go back to the last question here. So, any ideas what you guys want to do at this point? Up in the chat just yet. Hopefully, guys, if you're doing your viewing party, you're all screaming at the screen together to be like, oh yeah, obviously it's this. So, the biggest thing I would say just looking at this is the fact that this patient has vital signs are not where we want them to be. He's hypotensive, he's bradycardic. Why would he be in this sort of situation here, right? So look at the medication list. He's on carvedilol and he's on diltiazem. Does it make sense to be on a non-dihydropyridine, calcium channel blocker, and a beta blocker together? Probably not, right? And again, that definitely explains the heart rate of 50. Now, keep in mind that, as far as anti-anginal therapy goes, carvedilol or diltiazem can be useful because they go ahead and they will decrease the oxygen demand by the heart. That is only to a point. If you continue decreasing it too much, then the heart just cannot keep up and it cannot pump enough blood to actually perfuse the body. And so in that point there, you're kind of fighting yourself a little bit. So there's got to be a sweet spot there. And getting the patient down to heart rate of 50 with an AV block is not the way to do it, right? Right. So, looking at this, so what meds does this patient need to be on based on his history, right? So, carvedilol makes sense because he has a previous MI. Lisinopril absolutely makes sense there. The aspirin, let me see. Odalis says you can either keep him on a beta blocker plus DHP, or could you just do the non-DHP alone? Also, get him onto IV nitroglycerin to get him stable. So this patient is stable right now, right? So if you're looking at this, his blood pressure, he's pleasant, cooperative man, no acute distress. So his vital signs are low, but I wouldn't say he's like unstable at this point because he's still awake. He's still communicating normally. If he was like had a syncopal episode, or if he was, at ultramental status or something like that, then I'd be more concerned about him. But also, you wouldn't want to put him on IV nitroglycerin because the patient's already hypotensive, right? So that's just fighting him. So not only is he on an elevated dose or a higher dose of his isosorbide mononitrate, which is lowers blood pressure, he's on carvedilol and the non-DHP together. So again, all these things are working together in order to get this blood pressure and heart rate kind of where they're at. So that's kind of where we're at in terms of that. So let's look at the other medications he's on. Should he be on those, etc. Now looking at celecoxib, that makes sense. Not really any big drug interactions there to note. Now this guy is super high risk for future MIs, right? They even saw that on the angiogram. Is simvastatin appropriate for this type of patient? Well, if you go back and look, this patient's really high risk. He probably needs to be on a high intensity statin. And when you go back and look at it, you're going to find that simvastatin 40 is not going to cut it. So he probably needs to be switched out to something like atorvastatin or rosuvastatin. And that makes sense too, because if you look at his actual lipid profile, it's not looking great, right? We definitely have some room to go here. And so based on the guidelines, we don't shoot towards specific numbers anymore per se, but certainly we can go ahead and get him on more intensive therapy from that standpoint to try to get that under control and get him that mortality benefits that we see with high intensity statin use, right? So what would I do right away? I'd probably say stop the diltiazem because this patient has a better compelling indication to be on a beta blocker than they do to be on a non-DHP. Let's say get rid of the diltiazem. We don't need it right now. Okay. See where his blood pressure is going to go. See where his heart rate is going to go. The other thing you want to do too, when you're talking to these patients, is see when's the last time they took their medications. They take them that morning. They take them at nighttime in relation to when you're talking to them. Because if they just took it, then you're probably seeing peak dose effects versus if it's been like a day or two, then the drug's probably out of the system. But this guy probably took it that morning, and now we're seeing him say at lunchtime or in the afternoon. So I'd be cautious with isosorbide mononitrate. I'd probably go down on the dose, if not just discontinue it altogether, because of the fact that, again, the patient blood pressure is pretty marginal. So those would be the things I'd probably like shoot for first, is probably either lower the dose of the isosorbide mononitrate, at the very least, definitely get rid of the diltiazem and kind of go from there to see where the patient's at. And change the simvastatin out probably to something like rosuvastatin, 10 or 20, something like that, would make a good sense there. Now, the complicating factor too is you got to think, like, what's the St. John's wort here do? This is something, if you're not familiar, it's a dietary supplement, or it's an herbal medication that you can find pretty much anywhere you go. There was herbal supplements. Now, St. John's wort is actually really notable because it has several different drug interactions that you can see here. St. John's wort is actually a pretty potent CYP3A4 inducer, which is notable. It's not an inhibitor, it's an inducer. So that actually is probably increasing the metabolism of the diltiazem, leading it to not be really all that effective. So not only do you have the issue of the St. John's wort interacting with the diltiazem, it's like we just need to get rid of those anyway. So now, I'm not saying get rid of St. John's wort necessarily. You may talk to the patient to be like, hey, is that working for you? Is it not? Is there something that maybe you could switch them to that would miss those drug interactions? We'll talk more about treatment for depression next semester, but just another thing to keep in the back of your mind. So right away, I would decrease the dose of the isosorbide mononitrate, get rid of the diltiazem, and change out the statin. Now you're thinking like, well, how would this patient have ever gotten on carvedilol and diltiazem in the first place, right? remember, people don't just see you as their only provider. If you're working like in, you know, a family practice or internal med or something, they see a lot of providers, see specialists. And so this is something I really harp on, and I hope you all will think about this when you're practicing, is the fact that you might be the one person who gets to see them between all their different specialists. And so you have, you're sort of the cornerstone there of their therapy. And so you need to be looking at that med list to see, okay, well, this provider ordered this other provider ordered that, and there's a big interaction happening here. You need the person to be able to do something about that. And the problem you run into with a lot of providers is that they don't want to step on each other's toes. So when they're looking at that, they'd be like, I don't necessarily want to stop that diltiazem, even though the patient's hypotensive bradycardic, because their cardiologist went ahead and wrote for that, and they must have done it for a good reason, so I'm not going to touch it. And you'll see patients will continue on these adverse effects for years sometimes because no one just picks up the phone and calls somebody else. And again, it's tough because it's busy. You guys see a lot of patients, but you might be that only person that notices this stuff to be able to call and get these changes made. So just something to consider there. So those are the main cases we went through. Hopefully, guys. If the patient returns in 2 weeks for a follow-up, how will you evaluate a response for his new anti-anginal regimen? Probably asking like, well, how are the headaches doing? Are the headaches going away? Because again, headaches are due to the nitrates, right? I'd ask about how much activity can he do before he has symptoms. So is he able to golf again, right? Without too much problem. I would ask about how many sublingual nitroglycerins he's having to use during the week. See if that's going down. Hopefully, if the therapy is going well, that will have gone down, and all of that. So those are probably the big things I would probably find out on follow-up there. So I know it's a little bit of an odd lecture, kind of rambly, and then kind of just going kind of flight of thought, but hopefully it gives you some ideas of the thought process when evaluating a case like this, and sort of things I think about when writing test questions, for instance. So nothing from these cases specifically will be on the exam, but similar things may come up. Drug interactions we talked about, appropriate therapy for things like hyperlipidemia and high-risk patients, things like that can potentially come up. So what questions do you have now before I let you all go? So the test will be next week. I think it's on Wednesday. We can confirm that, and then you'll be done with me for the semester at least. I'll get those prescription assignments graded, and then you guys will be all good to go, I think. If nothing else, I will probably see you next semester since this is my last video, but I'll send some announcements out about the tests and stuff when I get more info or after you guys are done with that. So otherwise, hope you all have a great week. And if you have questions in the meantime, I'm obviously not going to be checking the sticky board anymore for this particular class. So email me if you have questions on stuff for the test. That way I can get back to you. Yeah, you all have a happy holidays too. Stay safe out there. I'm sure you've been looking at the coronavirus cases are going up. So just be careful whatever you do. And hopefully stay healthy and happy and come back next semester. You guys have a great break from me for sure. All right, I'll see you guys later.